is patient does not have hemodynamic collapse. Do you thrombolize or do you anticoagulate? That's the rough question. So how can one identify a high risk in the intermediate? So this is called intermediate high risk, suitable for pulmonary embolism and thrombolysis. And what those and advantages over anticoagulation alone?
Good afternoon and thank you, Kamal. This is the last session. I think regarding the management of intermediate high-risk pulmonary embolism. As we have gone through so many lectures, I think Kamal would agree that internally we all are confused. Externally, we all look satisfied. Similarly, this is the another situation. Intermediate high-risk pulmonary embolism, how to manage. This is the patient. The important thing is that we have to build or that is the pulmonary embolism team and network. This is very important. And age is 32, male patient, history of air travel. Heart rate is 120, which is more than systolic pressure, which is very important index. Positive troponin and high anti-proBNP level. Good LV function and TAPS is 11 and PA pressure is 55 over science 60-60 that if LV pressure is less than 16 acute pulmonary embolism, oxygen saturation is 95 dBT and high D-dimer. So how can we stratify these patients? There are so many scores are there. If you look at the PASI score, that is 82 points, is class 2 low mortality. If you go for the simplified version of the PASI score, then it's one or more than 1 point which falls into the high risk score. Then the STR score and the BOA score. If you look at the BOA score, points are 5 and it's fall into high risk. So this is the situation. Sometimes some parameters they are saying that it's low risk, some parameters they are saying which is high risk. But important thing is how can we classify the intermediate high risk patient. Hemodynamic instability, which is very important, which differentiate between these two, that is the high risk versus intermediate high risk. Positive PASI score, I mean, that is 3 or more than that, the simplified version, which is 1 or more. RV dysfunction and elevated biomarkers, this is very important. So if there is one of them, then it falls into the intermediate dose. This is the patient having the intermediate high risk score. Only these things are important when the patient is having the pulmonary embolism because even after this, so many things we have to look into these patients apart from just CT pulmonary angio where the Miller score, what is the thrombus burden is there. Important thing would be the lactate level because sometimes the patient they appear having normal blood pressure, but there may be normal tensive shock. So in that condition, we have to look for the lactate. Apart from that, important thing would be the RV-LV ratio, perhaps less than 16. Inferior dilatation and the regurgitation of the diet during the pulmonary angio, which comes into the inferior vena cava, annular velocity of the tricuspid valve, RV OT and the LVOT, whatever the velocity, which are very important. So many things we have to look into the pulmonary embolism, and then we can actually stratify the patient. These are the various scales and the score, but there are some pitfalls. That is like that. What if the patient is having the associated comorbidities, history of syncope, heart rate is more than systolic pressure, and clot in transit? Then what should be done? Patient is having the PFO, can be changed if they're having the small ASD, LV dysfunction. So many things we have to also look into the matter when we are treating the patient is having pulmonary embolism. One thing is that under usage of the thrombolytic therapy in this patient, it is also very, very important. Now, this is the slide of the intermediate high risk patient of the pulmonary embolism saying the rescue thrombolytic therapy, which is class 1B for the hemodynamic deterioration. So that is the word which is very catchy, hemodynamic deterioration. So whether this is the right word, I think hemodynamic deterioration is not that important, but the important thing would be if the patient is not improving, like if the pulse is persistently staying high, the lactate is staying same. So I would say instead of talking about hemodynamic deterioration, we should say that if the patient is not improving in spite of the therapy, so that will help us to treat the patient properly. So normotensive shock means the patient is having the normal blood pressure, lactate is very high, persistent tachycardia. So this is the patient that we have to identify that these are really, though it is intermediate high risk, but they can deteriorate at any time. There are 3 out of 4 pathways are there. The CPS4 is there. And I will like to skip this last slide, that is the intermediate high risk. The monitoring is important. If the patient stays stable for 24 to 48 hours, no, then systemic thrombolysis is important. And if it is successful, then anticoagulation, it is important. But if the patients, they are not stable, then catheter-directed intervention, because the catheter-directed thrombolysis is also important. How much one should wait? Though it is 24 to 48 hours, but I would say the 6 hours. If the patient is not improving, then I think we have to take the next session. I mean, next step. And if the CDI is available in less 90 minutes, then we have to go for that. So thank you very much. And I think just like the primary angioplasty, when we were thrombolizing the patient, and now it's an adult primary angioplasty. So I think now this also from the thrombolysis probably in the coming time we are going to do just like in this patient, we may go for the catheter-directed interventions. I think the last slide of the dosages. If we are going for the catheter-directed thrombolysis, then the low dosage, that is 0.5 to 1 milligram per hour per catheter, means if the patient is having the thrombus on the both side, then we can put the 2 catheters, and per catheter, that is the dose, that is the catheter-directed. And if we are going for the TPA, then I think 100 milligram over the 2 hours. And streptopinase, all of us, we are using the 2.5 lakhs and then 1 lakh per hour and like leucopinase. So this is the various therapy, and most important is the catheter-directed therapy. Thank you very much.
Thank you, Dr. Bhupesh. And finally, we have Dr. Bhavesh Roy to talk about anticoagulation is another effective strategy to treat intermediate risk pulmonary embolism. Dr. Bhavesh Roy.
Good afternoon. Thank you, Kamal Bhai, and dignitaries and the cardiac team. So, to summarize, the pulmonary embolism, nicely told by the Bhupesh sir, it is on the spectrum of the disease. How we see pulmonary embolism, one patient may not be the same as the second, third, and fourth, and even 100 number of patients. This is the one scenario given to us. We will go into the detail of that in 2 minutes. 32-year-old male. He's a very young patient. Number one, he had a recent long distance hair fall. He had a calf pain for 12 hours. So it is going on since many probably days. His ECG shows sinus tachycardia, as rightly said, 120 per minute, troponin is positive, RVSP is 55. I would like to tell one pearl, if patient is generating RVSP 55, it is very likely that it is acute or chronic pulmonary embolism also. Acute pulmonary embolism without chronicity cannot generate RVSP of 55. So if patient is generating 55, he had some exposure of PE prior. He had a dilated RARV with the TAPSE of 11 only. That also says that with 120 heart rate, if you are having TAPSE of 11 only, that also says some RV overload going on since long. And also desaturation. Young patient with this 95 saturation and heavy thrombus burden. Acute is not mentioned, but it is a bilateral lower limb DVT. So it is likely that he is having hypercoagulable state disorder. I would like to find out whether he had another episode of previous or not by the venous Doppler. And one thing which is missing here is that what is the CT pulmonary angio? As professors rightly say that we are moving in the era of intervention. I will go to this slide first. How it started. For myocardial infarction, we started with the armchair therapy with the heparin, and then came the thrombolysis, and then came the angioplasty. Initially for the stable patients, then for the relatively unstable patient, and then it became a mainstay, AMI. How the stroke is behaving. It started with the anticoagulation only, then went into thrombolysis, and now stroke is in a palmy neck situation. Every stroke is like a code blue. Patient is considered to be fit or not for the mechanical thrombectomy. And the same way we are moving towards the venous thromboembolism. Initially, it is an anticoagulation only, as for this patient maybe, but later on, patient will be for the thrombolysis as it is a troponin positive with RV strain, with pH, RNA dilated, but now patient will be subjected to the mechanical thrombectomy also. Now coming to this one pyramid, which I wanted to highlight, there is a heterogeneity of data and there is a very less number of data for which there is an agreement. So low dose identification of the low risk P, we are agreed. IVC filter in a contraindicated patient for the anticoagulation, we are agreed. Systemic fibrinolysis in unstable patient, all will accept. But see the middle one. There is an agreement on the at least only 50% of the trial. And this is the confusing area or dilemma area. What is the optimal duration? Whether to start oral Xarelto or Episaban directly without LMWH? What is the risk stratification for the PE treatment later on? Whether CTPH will happen or not? Whether this patient should have an indoor or OPD based treatment? And whether intermediate risk patient with how they will behave later on. There is no consensus for that. Use this score and understand that plus 20, plus 30, plus 20, plus 20, plus 20. Age itself is a score. If patient is 65, 75, itself becomes a moderate risk. After that, if we are adding tachycardia, hypotension, tachypnea, this whole hemodynamic instability in a modified simplified PASI score itself says that this patient comes in an intermediate high risk category, already troponin positive. And if I'm adding this patient to this CTPA, suppose this gentleman was suspecting this is a normotensive looking patient, but patient is in shock. If we do the right heart cath, if we do the lactate, if we get the venous central line saturation only, mixed venous O2, it will be low. And if suppose this patient turned out to be like this saddle thrombus or RPA total, LPA total, thrombolysis is must, and I will rather tell that apart from the thrombolysis, this patient should go for the mechanical thrombectomy. And why he should go for the mechanical thrombectomy for this thing? Majority of the patients, sorry, the data is not being shown. Majority of the patients of this type of patients do have a significant pulmonary thrombus burden, and they went for the residual pulmonary vascular obstructive disease. Like in a post-thrombotic syndrome in DVT, these are the patients who develop continuation of deterioration of 6-minute walk test, and after 6 months, 12 months also, functional class limitation is still there. Coming to the duration. Second question to this gentleman. Suppose we have completed the primary treatment of the thrombolysis or the catheter type of thrombolysis, and how long the anticoagulation will be continued? Very difficult to answer. Hematology should be in the picture. What are the data says that you try to identify which are the patients who had done a provoked DVT versus unprovoked DVT. So this is the first, all patients with PE should receive 3 to 6 months of anticoagulation. After withdrawal of anticoagulation treatment, the risk of recurrence is very high for the first 12 to 24 months, but there are no data which says that whether this patient should be on anticoagulation or not. Extended duration of anticoagulation is at the risk of bleeding, very high risk of 3% per year risk of major bleeding. So I will tell to this thing, real question is not whether it should be 3-6 months. How you will identify that these are the patients who are likely to develop a second event? If malignancy, active malignancy, already had 2 episodes, this was the second episode. Family history, we had 3 patients whose father got thrombolized and the daughter had a pregnancy. During pregnancy, patient developed thrombosis, pulmonary thrombosis. Patient having APLAS, first episode presenting itself as a massive PE, in situ thrombus or the thrombus in migration. Persistently, chronically inflammatory states and unprovoked first event at a younger age with a strong family history. So these are the scenarios given that suppose patient is having intermediate high risk and they have a minor surgery for more than 30 minutes, admission for more than 3 days, estrogen therapy, pregnancy. These are the event in which the first event has occurred. You may consider continuing the anticoagulation for the long. For the sake of the time, I will not go for the detail of the doses of the Ixaban or Rivaroxaban. It is easily available in all the guidelines. So take home message is that only. These are the normotensive shock patients. Thrombolize them. If the facility is available, if the expertise is available, go for the thrombectomy device. Thank you.